Hello, and welcome to our third annual Empower Conference. My name is Dr. Reshma Matani, and I'm a medical oncologist whose practice is focused on breast cancer at the Sylvester Cancer Center, University of Miami, where I co-lead our breast cancer program. By way of background about this meeting, a few years ago, I had a dream to organize a gathering where we could bring together patients, their families, and members of their healthcare team into one room for a day-long meeting. I was hoping to have an honest and open dialogue about all the things that patients and those who are caring for them struggle with, from treatment decisions to how to balance toxicities and benefits of our therapies, to how we can use various support services to help our patients through their breast cancer journey. During our busy clinic days, we don't always get the time we want with our patients and the time that we need with them. And similarly, I hear very commonly that patients and their family members have gaps in their understanding. And this meeting was intended to bridge those gaps. So with the help of the amazing team at Total Health Conferencing, we had our first meeting. It was a resounding success, and I encourage you to view video highlights and pics from that beautiful day a few years ago on the Total Health website. So where are we now? Well, we weren't going to let a pandemic get in the way because cancer treatment must go on. And so like many events of late, we've pivoted to a virtual format for the last couple of years, but we certainly haven't lost the energy and enthusiasm to bring us all together to have these important discussions. So today I am pleased to have with me a multidisciplinary group of physicians who are experts in their field for a panel discussion on breast cancer. And I'll start by asking each of them to introduce themselves, say a bit about what they do and where they practice. So I'll start with you, Stephanie.
Sure, my name is Dr. Stephanie Graf, and I am a breast medical oncologist at Brown University and the Lifespan Cancer Institute in Providence, Rhode Island. And I take care of people with breast cancer all day long.
Thank you. Mediget?
Hi, everyone. I'm Mediget Teshome. I'm a breast surgical oncologist at MD Anderson Cancer Center here in Houston, Texas, and excited to be with you all today. Very passionate about making sure our patients are empowered in their decision-making.
Great. Thank you for being here. And last but not least, Kristina?
And I'm Dr. Christina Mirabeau Beale. I'm a board-certified radiation oncologist with Genesis Care USA. I'm based in Southwest Florida, where I'm the director of our Regional Cancer Center's breast program in Fort Myers. And I'm excited to be here and learn with you all.
Great. We have a great group, and I know we're going to have a wonderful discussion. So the format for this session is that I'll be guiding a discussion, and the first topic is FAQs, or frequently asked questions. So before the meeting, we asked each of our experts to provide a list of the 5 to 7 most common questions they hear in their clinics every day from patients. And we may not get through everyone's questions, but we will do our best, and we want to keep this as a free-flowing, open conversation. So I will start with Kristina, the first question you provided, which is with regards to radiation therapy. What happens if I miss a treatment? Will my cancer grow back?
So a lot of this depends on kind of the circumstance around radiation therapy, but generally treatments are given Monday through Fridays with weekends off. And a lot of this is about balancing both kind of the cancer killing effect of the radiation while also managing the side effects, because normal tissues will respond to radiation as well, and the effect is cumulative. In the situation with most breast cancers, since patients have generally had surgery, we're treating more as an insurance policy. So there isn't usually gross disease left behind. So while it's optimal to have treatments, without interruptions, especially, for example, as we're getting into this last quarter of the year where there are a lot of holidays, for example, we are able to make some compromises. And so usually if it ends up being, for example, a 4-day week, that's okay. And what we can also do sometimes as a compromise is give 2 treatments on a given day separated by about 6 hours if necessary. So we try to be very individualized with the patients. So big picture, yes, we like them to be compliant and not miss treatments, but we are able to have some flexibility, especially since usually these patients don't have gross disease left behind.
Thanks. That's a great background. And I think, even as medical oncologists, and Stephanie, I'm sure you hear this quite a bit, patients often get very panicked when they miss their treatments so in terms of our treatment, sometimes patients come in and they're neutropenic or they're not able to get their therapy in that week. And Stephanie, how do you handle those conversations from the medical oncology standpoint?
What I tell patients is that all of the cancer treatments that we regularly prescribed in clinic are based on clinical trials. And in a clinical trial, there is a very carefully prescribed protocol that tells us what to do when somebody's blood counts are too low, or they're having numbness in their fingers, or sores in their mouth, or an infection. And those protocols say, hold the treatment. And so a certain percentage of patients on all of the studies that show that these drugs work had their treatment held for a week, for 2 weeks, until they felt better. And those patients' outcomes were included in the outcomes that showed that these drugs were effective, that led to them being the standard of care. And so this patient in front of me, the patient asking the question that's having this rough day leading to this conversation, is no different than that patient on the clinical trial that led to this being the standard of care. And so although it stinks that they're in that situation, they're no different, and we know that what we're doing is evidence-based, and they should feel safe and comfortable knowing that we need that break in order for them to be safe.
Absolutely. So Mediget, after our breast medical oncology or our breast radiation, our breast radiology colleagues, who often are the first ones that give the news to a patient that they have breast cancer, a breast surgeon tends to be one of the first surgeons that a patient sees. And I'm sure you get this question quite a bit with regards to what is my prognosis. Patients are scared and they're newly diagnosed. They're looking to you to answer a lot of questions. It's a broad question. I'll ask you, how do you handle that?
I think the first thing that I want patients to know is that we have very effective treatments for breast cancer. So I always tell them, the most important thing is for us to understand the stage of disease, as well as the type of breast cancer or the subtype, looking at the estrogen, progesterone, and HER2 receptors. And that based on this, we'll be able to work as a team to guide their treatment. Surgery is not alone, good enough treatment. It really takes a team approach, as you've assembled here today, and that together we can provide the best outcome for that patient. And oftentimes the prognosis will depend on the surgical pathology results. So at that moment in time, we may not have all the information that we need to guide that or to be able to answer their questions. So that's how I start to approach that discussion. And I really do think that the more information we're able to gather, the more clear we can, guide them as to what to expect in the future.
Yeah, I think you bring up a really great point. The theme that I hear quite a bit in terms of understanding their journey ahead of them is that patients are always distraught about this aspect of the waiting, right? So we're waiting on the pathology, we're waiting for the diagnostic assay, we're waiting to get all the information, and there's a sense of panic. Stephanie, how do you handle that? I think as a medical oncologist, we do a lot of hand-holding and support, but do you have any tricks of the trade there that you can share with us?
I just named the elephant in the room. I don't know if it's helpful, but I think just acknowledging that that's normal. It's normal to feel anxious. It's normal for everybody's first instinct is to just want surgery right there in my exam room, even though I'm not the surgeon. I think in terms of prognosis, I tell patients that the prognosis is a rolling prognosis, what we know the day of their biopsy versus 2 days later when we have their prognostic markers versus 2 weeks or 2 months later when we have their 21 gene recurrence score versus 4 months later when we know what their response to neoadjuvant chemo was, are all very different time points versus 3 years later when we know if they've had an early recurrence. All of that information changes what I can tell them about their overall prognosis. And so some of it is just settling into the uncertainty, and that's a really uncomfortable place to be. And so I just try to acknowledge that and give the patient space to express that fear and uncertainty, and be there for them.
Yeah, I love how you put that, settling into the uncertainty. That's really nicely stated. I think it's very, very difficult for all of these patients and their family members, and having the support of their team is certainly essential. So Christina, I know as a medical oncologist, we get this question quite a bit in terms of our adjuvant therapies, and it sounds like you get it as well. But my surgeon got it all. Why do I need radiation or chemo, or fill in the blank for all the therapies now we're adding on after surgery?
So I like to kind of frame, I guess, the historical paradigms that kind of have brought us to modern day, radiation for breast cancer. So historically, we used to do mastectomies for everybody. It didn't matter how big or small the cancers were. And, when we had the earlier NSABP studies that really looked at mastectomy versus lumpectomy alone, we found that for a lot of women, the risk of recurrence was unacceptably high. And so then by adding ionizing radiation, we were able to really kill microscopic disease and prevent a recurrence in the long term. So, usually I frame it as, you're able to keep your breast if we're doing breast conservation, but depending on the situation and the biology, the radiation is needed as an adjunct to really kill microscopic disease to prevent a recurrence in the long term. And then when we start looking at patients who have more favorable prognosis, so our, patients over 65, for example, with small ER positive disease, then we can talk about how, the improvements in systemic therapies have, led to pretty equivalent outcomes in overall survival. And so the real benefit for radiation there is local control, but even that can be factored in on kind of a case-by-case basis, depending on a patient's comorbidities and other issues, to know whether we need to be maximally aggressive in terms of the radiation, whether we need to, adjust and do more of a shorter course, versus whether radiation can be safely omitted.
Mm-hmm.
I actually have a really great analogy for this, but what I tell patients, which is ridiculously simplistic, but I tell patients that I think that the lay public thinks that cancer is a pea that grows into a marble, that grows into a bouncy ball, that grows into a tennis ball. And instead, it's a whole lot more like if you hold your salt shaker upside down on your kitchen counter, you're going to get a pile of salt. And the bigger the pile of salt gets, the more salt is going to be all over your kitchen counter. And when the surgeon comes in and says, I got it all, they mean they took away the pile of salt, but it doesn't mean that they cleared off your kitchen counter.
Oh, wow,
And the
I love that.
radiation oncologist is the person who clears off your kitchen counter. And even when the surgeon did a mastectomy, if you had a 5-centimeter tumor, they didn't take your skin or your chest wall muscle or your entire armpit off of your body. The radiation oncologist still has a counter that they need to clear off. And so a lot of the times I tell my patients that the radiation oncologist needs to clear off their salt sprinkles, and then they go to radiation oncology and they're like, I'm here for my salt sprinkles. And my radiation oncologist are like, what are they telling you?
Well, I love that. I think I'm going to steal that. That's such a great analogy. Yeah. So Mediget, one thing that we're seeing quite a bit, I'm sure you struggle with this quite a bit in your practice, is talking patients back from doing more extensive surgical procedures. We see this quite a bit. A woman finds out that she has breast cancer. She's, distraught, panicked, and now we send her for an MRI. We're starting to see the incidence of or the chance that someone's going to go and have a bilateral mastectomy increasing as we're doing more MRIs on patients and finding things in the other breast or other lesions in the same breast. And patients don't want to wait and go for additional biopsies. And sometimes they just say, that's it, I want to have a bilateral mastectomy. What does that conversation sound like in your clinic?
No, that's a great point. And honestly, I think it comes up very frequently, this discussion about the other breast, which oftentimes appears normal. So I think that in the situation that you described, if there is a workup that is going on, it is really important to complete that workup, because if there is a cancer that is diagnosed in the other breast, it does change our surgical decision-making. We would also check the lymph node status at the time of surgery. So if that is an issue, I do always want to make sure that we completely work it up. But let's say that it's a scenario where the breast is otherwise normal by MRI, et cetera, and a patient who does not have an elevated risk of a future breast cancer from a genetic mutation or strong family history, then, what I try to focus patients on is that really the main concern or risk is the cancer that we know and that we see. And so it is best to stay as laser focused on that as possible. And, studies have shown us that there is not a survival benefit to removing the other breast, and it may not otherwise impact at all their treatment for this known breast cancer. So I do think it is a highly individualized and personalized decision. And so I always want to kind of walk through it with patients. But as you mentioned, that first visit, it's something I think to start to discuss. And if more questions are there, then we can discuss it further, in subsequent visits. But I do try to stay focused on the cancer. If I could just add to the last question that you posed, breast cancer is really a systemic disease. So that's kind of the way that I pose it to patients. Although there's a localized problem that, of course, we can treat oftentimes with surgery alone, surgery alone is not enough treatment. And that's why sometimes we even will recommend medical treatment before surgery.
No, great. Please, anyone, feel free, jump in. We can go back to other questions. We want to keep it open and free flowing. So Stephanie, you talked about the elephant in the room previously with regards to the anxiety. I think the other elephant in the room that we always kind of face is this whole question of why me, right? We know that hereditary breast cancers account for actually a minority of all the women and men who are, well, maybe more in men, but who are diagnosed with breast cancer. But I think that this is something that patients tend to struggle with when they're diagnosed, especially when they have no family history, when they're young, when they quote unquote did everything right. How do you handle that big question?
Yeah, I mean, at the end of the day, I think the answer for most patients, unfortunately, is just bad luck, which isn't necessarily comforting or an answer to the question. So sometimes I start just by asking if they could help me understand why they're asking, because I think that sometimes they're asking because they really want to understand what risk factors they need to work with their sister or their daughter or their mother on, because they're now worried. As women, we're such caregivers, and they're now automatically, they've moved beyond themselves and are worried about this league of women that surround them and how they're going to stop what's happened to them from happening from the other people in their lives. But sometimes they're trying to figure out how they can be their healthiest selves beyond breast cancer. Like, this happened once, what do I need to change so that it never happens again? And those are very important questions that we need to talk about. Could they lose weight? Could they have a healthier lifestyle? Could they minimize alcohol content? Do they need genetic testing? Those are all very important questions that need to be addressed. But at the end of the day, I could line up, these are the 10 things that are risk factors for breast cancer, and some of them may be modifiable and some of them may not. And 1,000 other people may have those same risk factors, and half of them may get breast cancer and half of them may not. And I can't say why you versus why not you. And, that's kind of the conversation I have with patients when they ask that question. I'd be interested what the other panelists say.
I think from my standpoint, I just try to, like you said, reassure the patient that really there's nothing that they did that we can pinpoint caused this cancer. And, I think in a genetic mutation carrier, maybe we have a more clear, causal link there, but that's exactly what I just try to reassure them, that they did nothing wrong.
Mm-hmm. So in the few minutes that we have left for this part of this session, I want to turn to a discussion about the toxicities of our treatment. And I think that we've done a great job in treating breast cancer in terms of peeling back on surgical procedures and refining our radiation techniques and individualizing systemic treatment therapies in terms of chemo and hormonal therapy. But unfortunately, all of these treatments, despite our improvements, still have toxicities. And many patients are particularly concerned, especially when it comes to chemotherapy and as far as damaging healthy cells, even radiation therapy, we hear that quite a bit. And then, of course, with our surgical procedures, there are risks, including infection, time under anesthesia, problems with implants, lymphedema, which is a huge one. So I'll just ask each of you individually to give me sort of your spiel on how you talk to patients and help them try to balance those benefits and toxicities. So from the medical oncology standpoint, Stephanie, I'll ask you to start.
Well, I give a lot of medicines that cause a lot of different side effects. So in a nutshell, I guess my points would first be that just because a side effect can happen doesn't mean that it will happen. I think that's a misperception. Sometimes patients will get those printouts from their pharmacy of what the side effects may be, and they'll be like, I'm never taking this. And I'm like, whoa, whoa, whoa. Just because it says that doesn't mean that that will happen. Secondly, if you develop a symptom or side effect, if you think you may have a symptom or side effect, if you read about a symptom or side effect on Facebook or Google or hear about it from your great Aunt Marge, tell me about it. Let's talk about it. I want to know. I want to talk about it because I might have a trick. It might be real. It might not be real, but the only way is for you and I to have a conversation. So bring it up. And third, just, you know, again, there's so much that we've advanced in the last decade to make chemotherapy side effects better, that a lot of the data and science that we have looking at late side effects, the side effects that can happen 20 years down the road, is based on data we collected 20 years ago. And so the late side effects of chemo aren't the late side effects of chemo because we've gotten a lot better in the last 20 years. So the truth is that I hope we're moving the mark forward. So it's hard to project what the future is really going to look like.
Yeah, and even I would just add to that and say even the acute side effects of chemo are not what some people have in mind, because, you know, we have such great supportive therapies for things like nausea and vomiting. We have a lot of improvements in the supportive therapy realm as well, not just pharmacologic improvements, but the recognition that survivorship is a thing, that patients need to have a certain quality of life, and we need attention to that in the future. So I think that we've come a far way from that standpoint. Christina, how do you handle these discussions from the radiation standpoint?
I think it's helpful to kind of talk about the kind of basic effect radiation has on cells. You know, radiation, the goal is to, you know, kill cancer cells by damaging their DNA. The radiation, that's how we improve our cure rates, but that also is going to bruise and affect our normal cells. And depending on where we're treating, that's how we manifest side effects. So in breast cancer, you know, the skin's affected, the tissues are affected, the muscles affected, and that's where you get breast swelling, tenderness, and the skin reaction. You know, normal healthy cells, because patients will often ask, well, if it's hurting my normal cells, why do I want to do this? You know, they have the DNA repair enzymes to kind of go through a cell cycle once a day. That's kind of why we treat once a day rather than, you know, high dose in a single treatment. And then in terms of the side effects, they tend to be gradual and cumulative. And very much, you know, related to the area of the body we're treating. So, you know, it's a different field in terms of skin reaction for just an intact breast versus a post-mastectomy situation where we're also treating regional lymph nodes. And so I try to sometimes almost draw on the patient while I'm doing my exam so they kind of have a sense of where the skin reaction is going to be, and it helps them kind of know what to anticipate. And then, you know, other nuances with the radiation, you know, for patients who either have an intact implant or getting a reconstruction. You know, in our institution, we'll frequently see patients in a multidisciplinary setting just so that, you know, they get to meet both the radiation oncologist and then their surgeon and their plastic surgeon as well, and talk about different options in terms of sequencing. So they understand that, you know, even though there are a lot of complications that can arise depending on kind of how their tissues react to treatment, that we're all on the same page in terms of getting them through the treatment. And so that generally kind of alleviates some of the anxiety. And then the other piece is to emphasize kind of a lot of the technologies that have improved. We have image guidance, our machines are more sophisticated. We do CT-based planning for everyone. So even something like proximity to the heart, we're able to measure that. So we're therefore able to spare the heart more. And then also kind of better elucidating like which population of women truly needs treatment. So by de-intensifying our treatments for some of our elderly patients, so they may not even need radiation, that's another way we're able to kind of minimize the side effects.
Thanks for those insights, really valuable. And Mediget, I'll ask you to comment from the surgical standpoint, especially with regards to a really feared side effect of surgery with in terms of lymphedema, and how do you even counsel patients on their risk of lymphedema and what they can do to prevent it or monitor?
Yeah, that's a great question. I mean, we definitely talk through all the potential risks of surgery like you had outlined. I think an important thing that doesn't always come up, but is really important for patients to know, is just the loss of sensation, especially after mastectomy, numbness and tingling that many can experience on the backside of the arm here with axillary surgery. And I think when it comes to lymphedema, I mean, I think probably almost every patient will ask about this, and we will of course mention and talk about it. So one important thing that I always want every patient to know is that this is something that they may not even see for like years after surgery. So it's not something that, you know, usually presents very quickly. Also, it can affect even just the fingers, you know, the hand. So it's something for them to watch out for. Of course, the risks are much lower with a sentinel lymph node biopsy, although not zero. So that is important that always we discuss it even with those patients as well. But with an axillary lymph node dissection, it is something that we can see more commonly, probably about even potentially up to a third of the time or even more, to be honest. So we have been working with closely with plastic surgeons in our group, and there's, you know, a lot of research that's being done in this area about more, I guess I would say, advanced techniques or different ways that we can reduce the risk. So something called axillary reverse lymphatic mapping, trying to understand the lymphatic drainage from the arm so that we can identify that. So we are really trying to make a lot of strides in this area. And I also do mention to them that if they do develop lymphedema, there are treatments now and that are getting better and better. And our plastic surgeons have some microsurgical techniques, and there are other, you know, I think there are some options for treatment, which is definitely an improvement from previous years. So
Absolutely.
that's kind of the way that I talk about that with them.
Well, I think, you know, it's really just very valuable to hear all of your insights, because I think that, as someone said earlier on in the discussion, treating patients with breast cancer is definitely a team approach. I think that having the input of all of our colleagues and coming together with a plan for patients really is reassuring, especially when we're all communicating and clearly outlining and saying the same things to patients. So thank you for this session. I hope the patients that are tuning in and family members found it valuable. We're hoping to see you all in person live next year, the pandemic permitting. Until then, stay safe, and thank you for attending.